My name's Angela Gregory and I work as a psychosexual therapist. I work in a hospital setting. We have a sexual problems clinic that see men and women with a range of different sexual problems. So basically on a day-to-day basis, I'm talking to men and women about a range of different sexual difficulties. The majority of our male patients will attend the clinic with erectile dysfunction, and most of them will be referred to us by either their GP or various hospital consultants that work in different specialties. So we'd see men referred from diabetic clinic, MS clinic. The spinal team also refers spinal patients into our clinic. So the majority will be presenting with erectile dysfunction. I mean, ideally, it's good if they bring a partner, but not every man has a partner. Not every partner wants to attend. And so if I see men and their partner's not with them, I always bear in mind, if I'm doing an assessment, to remember that if they are in a relationship, to remember to ask questions and keep in mind that they have got a partner, and that partner might impact on their treatment. In our clinic, initially, most people attend alone, but you know, some men do prefer to bring their partner if they've got one, but some men aren't in a relationship. So we tend to work with what we've got, but we'd always bear in mind, if they are in a relationship, that we might need to ask questions about the couple relationship in terms of treatment. Well, I think that's down to the importance of the assessment. So if you're doing an initial assessment, I would make sure, one, you take into account any medical history. You'd be looking at also questions about, you know, when was the last time they had sex? When was the last time they got a good erection? In terms of erections, one of the questions I always ask every man about masturbation, for example. So if you're asking questions about something like masturbation, and a man will say that he masturbates and his erections are fine, but he's having problems when he has sex with a partner, that would indicate that it's likely that the problem is more psychogenic than it is organic. Because if the erection works in one situation but not in another, it's unlikely to be organic. My experience of working with men is most of the men I see want there to be a physical reason for their erectile dysfunction. So a lot of them will go online, a lot of them will do a lot of research, they'll consult Dr. Google. They want to know a physical reason. Now, when they're told it's primarily psychogenic or psychological, for most people that isn't very helpful. So what I like to do is explain the physiology of stress and anxiety, so they understand even if there's no organic reason for their erectile dysfunction, there is still a physiological explanation in terms of the role of adrenaline and the impact that has on erectile function. So I think if you give them the rationale and it makes sense, they're more inclined to buy into the treatments that you might suggest. I would tend to deal with their primary concern. If the primary concern was about erectile dysfunction, I would see that as something that you would want to treat initially. Even, you know, using medication, we have medication in our clinic. So if you know, the quickest response to restoring erections is to give somebody a medical treatment. And so we would often see using medical treatments alongside therapy or counselling. So you're sort of doing a combination of treatments so that you can address the other issues. But I think if the primary concern is erectile dysfunction, you need to resolve the erectile dysfunction as soon as you can, because of course we all know if a man's got a lack of erections over a period of time, that has a negative impact on the endothelial function of the penis. So restoring the erections, if that's the primary concern, would be what I would focus on initially. But if then they had body image issues, you might want to address that psychologically. For all men, you get a much better erectile response the more relaxed you are. Your erections are under control of your parasympathetic nervous system, so the more relaxed a man is, the better the erections are going to be. So certainly we would look at things like, you know, how do you distract yourself from negative thinking? How can you focus more on relaxation? We might talk about lifestyle issues, regular exercise, ways of actually improving things from a more holistic perspective rather than, you know, just focusing on the erection. I mean, I think if you are dealing or seeing people, and certainly in Nottingham where I work, it's a multicultural, multi-ethnic city, So there are cultural differences to a degree, but you have to listen to the story of the man and find out what his expectations are in terms of treatment. So sometimes that can differ culturally, but in my experience, any man that has erectile dysfunction just wants it treated. And the problem, if it's not treated as soon as possible, is that what men do is they avoid being intimate. So when their erections don't work, they avoid being intimate with a partner. That then has a negative impact on the couple. So the longer a man has an erection problem, the more likely he is to avoid being intimate and avoid being sexual, which is then detrimental to the relationship. So I think whatever the culture, restoring the erection as soon as possible, whether it's through psychological help or physical help in terms of, medication or injections, you need to resolve the problem as soon as possible, for the man's self-esteem as well as the relationship. You do get some colleagues who would say, there are other ways of pleasuring a partner that don't involve penetration. But for a lot of people, it's incredibly important. So you do have to listen to what the desires are of that man and that relationship and make sure that what you're suggesting is actually appropriate. Because if they want penetration and that's the main focus of their, sexual enjoyment, then to suggest things that they won't engage with is not very productive. But for those that are willing to explore, then certainly there are, as one person once said, you have 10 fingers and a tongue. So there are different ways of pleasuring. And also men can get pleasure from a soft penis and they can actually ejaculate with a soft penis. So, but again, it's dependent on what the expectations are of that man and that relationship. So masturbation is a key question in my assessment. I think if a man is struggling to get an erection with a partner but has no problems with masturbation, it might be that they need to reduce their masturbatory habit in order to enjoy good arousal when they're with a partner. However, if you've got a man who's got organic disease, maybe he's on his own, or and maybe you think stimulation of the penis would actually be good for his arousal, then sometimes I might recommend it. I think it's about getting the information from the patient first, and then you know whether they need to reduce masturbation to help their arousal, or whether you would encourage some self-stimulation and masturbation to help with blood flow. Also, some people have techniques of masturbation that are not helpful in achieving sufficient arousal with a partner. So in those cases, I might put them on a masturbatory retraining program. So there are lots of options for masturbation. I think that should be a whole section in itself, really. To be honest, I've been talking about it for so long that really it's like I'm talking about a shopping list. It has absolutely no impact. And there is no fast way to get confidence. You just have to do it. And the more you talk about sex, the more normal it feels, because the patients are watching you. So if you're not comfortable as a clinician or a nurse or a therapist, they will know and they'll pick up on those cues. So I think it's a responsibility of us all to get more confident in talking about sexual matters, because it's so important for most people's quality of life. It's a quality of life issue. So if you're seeing, for example, a man with diabetes, you're checking his eyesight, you're checking, peripheral neuropathy in his feet, why aren't you asking him questions about his erections? Because it's a body part that's not getting the blood flow it needs. So I think any area, any clinical area where you know that the illness or the disease of the patients that you see could impact on their erectile functioning, then I think it should be mandatory that we ask about sexual function. Well, I think humour is always important. In our clinic, we might have a lot of tears, but we also have a lot of laughter. And I do think it's important, but people struggle. I mean, if we're saying that as clinicians might find it difficult to talk about sex, think what it's like for a patient in terms of talking to their partner. We don't find it easy as human beings, particularly, I don't know about other cultures, but in a British context, we don't find it easy to talk about sex. So if we can't talk about it and we can't do it, then the problem tends to stay hidden for a lot longer. The majority of patients that get referred into our clinic I would say I've already been tried on at least one PD5 inhibitor. So my assessment initially would be to find out more about what medication they tried, what dosage, how often, and to look at any sort of psychological or behavioural aspects that might be contributing to the failure of the medication. If it was appropriate, we might try them on a different PD5 inhibitor. I might suggest lots of other strategies for them as a couple, along with things like pelvic floor exercises, maybe restraining from masturbation. The other aspect is men often exhibit negative behaviours when they've had a problem. So things like testing out their erection to see whether it works. And unsurprisingly, it often doesn't, but that's because they're not aroused when they're doing it. If that wasn't the case, and I felt because of the disease progression or the illness that it was unlikely that the medications were going to help, or they'd already tried all those medications, the next line would be to move to second line treatments, which would be things like Cavajet or, Muse, or one of those other treatments, or a vacuum device. If we use a vacuum device in clinic, we also would suggest that they use it 10 minutes every day as an exerciser, so to help with blood flow, to help get confidence, because particularly if they've not had a good erection for a long time, they're going to need more than just a few tablets to help. If that then fails, then of course the next step would be to refer them to a urologist to discuss the possibility of having penile prosthesis. On occasions where that's relevant, sometimes we have more time than they might have in urology. So we would also, talk it through, have a look at what the options are, and for them to consider it, because sometimes, for some people it needs a bit of thought. We'd also suggest that they spoke to their partner or brought their partner into the clinic so we could discuss that as a couple. Well, only occasionally, because I think once they go ahead to urology, I'm presuming a lot of people are very satisfied with the treatment, so they wouldn't necessarily come back to see us. Or they get support from the nurse specialists that work in urology. Occasionally we've seen couples where, very rarely, but they may have had, the partner may have some issues, or it's just about getting used to a change and a different way of functioning. But I would say they're a very, very small minority. I mean, I would talk to all men about, as they get older, their erections can be a little more unreliable. And, it's not going to work in the same way as it did when they were 17. And sometimes that's an adjustment, because when something's always worked and then suddenly it becomes a little bit more variable in terms of responses, some men struggle with that adjustment. So it's being realistic with them. So, that's managing their expectations about what you can offer. But, if they can accept that variability, they're less likely to get stressed. They're less likely to be worrying about their performance, which is actually going to be good for their arousal. Because once you start worrying, regardless of the cause of the ED, once you start worrying before you've even got into a sexual encounter that you're going to fail, even if you've got organic disease, that's going to be the psychogenic component, because you're already worrying. Well, certainly if you thought that perhaps they may have low testosterone, for example, if they're diabetic, if they're older, if they're carrying a lot of, abdominal weight, then we might send them to get their testosterone checked to make sure that's not an issue. If you see a man who's maybe in his 60s, maybe it's been, some months or years since he had intercourse, if you're talking about resuming a sexual relationship, you need to ask them how their partner feels, because you also need to ascertain whether the partner's got any sexual issues. And certainly for women who are postmenopausal, there are issues with things like vaginal atrophy. And so, that needs addressing if you're going to help a couple who are older re-establish a successful sexual relationship. And there's lots of, easily available treatments to treat that. And I also think it's how it's presented. So not all sex therapists are necessarily work in a medical, I work in a medical setting as well, so I think you need a sex therapist that's comfortable with all the medical aspects as well, in terms of an understanding of it. But also I think it's how the doctor or urologist would explain why they were coming to see me. Because if it all sounds a bit vague and a bit too touchy-feely, I can imagine some men thinking, well, they don't. I think it's how it's sold in terms of how it would be helpful. So I think there's two things that might make a difference. You know what I think's really missing? I think what we don't value is talking and being listened to. Some of the men I see will often say, you're the first person who's listened to me, and they've seen multiple professionals, but everybody's so busy. But I have an hour. And there's a lot of power in just being listened to and somebody hearing what you've been through. Well, I think most of them go online for a start. I think there could be better information online. I think it takes a lot of guts for men to go and see a doctor to speak about sexual problems. I think it takes an awful lot of courage. So, of course, the first port of call in the UK would be the man's local doctor, his general practitioner. And then, of course, it's all dependent on how comfortable that doctor feels in talking about sexual issues and, you know, where he's going to refer. And my experience is they don't have a lot of time, and they will tend to refer perhaps without spending too much time talking to the man. And I think a lot of men miss having somebody that will take the time to listen. And I find that with women as well. Is people can have multiple appointments because everybody's so busy. People don't necessarily take the time, and I always think, you know, more time taken earlier would prevent some unnecessary, you know, visits to see doctors, etc., because somebody's taken the time to do a proper assessment and had the time to listen earlier on. So, for example, regardless of the cause of the erection problem, whether it's organic, psychogenic, I think a lot of them are mixed. You know, even if you've got a medical reason why you've got an erection problem, you're still going to have feelings and thoughts about it. So one of the things you can't do is stop negative thinking. You can't tell somebody, well, stop thinking about it. So what you would do is find ways to distract their thinking. So I would suggest things like some of the meditation apps, so the relaxation meditation apps you can get on your phone, so that they can do those regularly. You know, just listening to something once or twice isn't necessarily going to help. But if they get into the habit of regularly distracting their thinking by listening to something positive, and you could do those with the apps. So the apps are one thing. The other thing I might suggest is exercise. We know that's going to be good for their erections, good for their mental health. But you have to make it, you know, if they haven't got a lot of money, you're not going to be talking about going to the gym. You might be talking 20 minutes exercise. That's going to be good for glycemic control if they're diabetic. It's going to be good for their general health. You can get apps for fitness. So I tend to try and use some of the more modern technology to help men have some. I think they like to go away with practical things to do. So certainly I would suggest the apps. If they've got a problem with masturbation, you can get apps that help you control your masturbatory habit. So that you've got the NoFap app. That tells you how long you've stopped masturbating for, which can be quite helpful. Pelvic floor exercises. We teach all men pelvic floor exercises, particularly the older men where you think maybe the weaker pelvic floor has got something to do with it, with their erection problem. And certainly, you know, I would demonstrate in clinic about the importance of regularly doing pelvic floor exercises because that increases blood flow. And what you need for a good erection is blood flow. So there's a range of different techniques we use. Well, as I already mentioned, one of the common factors when men have erectile dysfunction is they start to avoid being intimate. They avoid being sexual and they avoid being intimate because they're worried about failure. And so if you're offering them a treatment, whether it's a PD5 inhibitor or vacuum device or injections, and they haven't been intimate or sexual for a long time, one, you have to make sure the partner's wanting to be sexual with them if they're in a relationship. But one of the things we suggest is they're intimate, but they don't attempt intercourse. So the rationale for that is to give the man and the woman, or two men, whatever the relationship is, very, very clear boundaries about what's expected. So if the boundaries are no attempt at intercourse, but they can pleasure in other ways, they can kiss, they can touch, they can have, you know, mutually masturbate, they can have oral sex, but they're not going to attempt intercourse if intercourse is the cause of their anxiety. then what can happen is if you do that on a few occasions, then they start to relax because you're not expecting a response. And so because they relax, they then get a better response from the medication if they're using it. So we often use clear boundaries with a couple who haven't been intimate for some time, so they can relax. The more relaxed they are, the better their arousal. So that is really quite important to offer that to a couple as a suggestion. So they start getting back in the habit of being intimate without the extra pressure to perform. Because let's face it, the penis has a starring role. You know, the erection starts penetration and ejaculation ends it. So there's an awful lot of pressure on the man. So sometimes, you know, suggesting they don't engage in that activity but do other things can be really helpful.